This is Dr. Gurney. I'm going to share just a quick case on a full mouth reconstruction with worn dentition using traditional crowns. Here's our patient. He presented to our office. We'll call him TJ. He was referred in, and in our office, ultimately, we have a wonderful lady to help assist us with gathering and welcoming that patient to our office. This is McKinley, and she'll do everything in preparation for our initial visit, which I'll call visit 1.1, which is our consultation. So in that process, she will call, discuss as many things she can with the patient, call the referring dentist in their office to gather as much already received data, so that we can be super prepared for that initial consultation. So she'll get that scheduled. I'll meet with him. We always start with a patient interview. I think the most important thing I can do at this point is to really understand them and their situation. Let them be heard. Then I'll finish that consultation really trying to understand what he would like me to do. Obviously, they don't always know what that is because they're being referred in, and being referred in is a scary thing because they're wondering, like, why can't my dentist take care of me? Why am I getting referred to a specialist? All these concerns. That's why I think it's really important to understand his situation and what he feels like he wants me to do to the best of his ability. We got down to the conclusion that he felt like he ground his teeth down to nothing, and he really wants to fix them and prevent it from going further. So at that point, we talked about our process, which would be gathering some information. So we turn him over to our assistant, and she'll help schedule that. And in that visit, we'll do the exam. I'm going to outline what that exam looks like, or that data gathering process. And so there's a portion that my team will gather, like my assistants and team members. And so in that process, they'll do the new patient studio photos, diagnostic photos, full mouth of x-rays, a CBCT if needed. They'll get diagnostic intraoral scans. In our office, it's a trios, and they'll do most of the tooth charting. And then I will collect data, and in that, I will gather a head and neck exam, a TMJ exam, aesthetic evaluation, an occlusal or bite evaluation, a tooth exam, and a gum tissue exam. And then the patient goes home. So after that visit's completed, they go home and I do some homework. But let me just walk through what my team gathers before I get in the room. Here's the photos that they will gather for me. They're super important as the patient goes home to have these. Gives me so much information about what is going on and how I can help treat the situation. So there's the series of photos that they'll receive. Then they'll get a full mouth series of x-rays. Here's the trios or intraoral scan data. I try to gather that data at the vertical I believe will be needed to help with his reconstruction. And so you'll see it's open. The teeth are not touching in this iOS scan. Here's the CBCT data. I've already loaded it in this image, obviously, with the implant planning software, which we use Code Diagnostics. And then I'll come in, and again, I'll show you that bite record is open. My assistants don't gather that. I'll help set that bite record. If I feel like the vertical is too overclosed or just feel like there needs to be more restorative space, then I will use a leaf gauge, kind of measure the space I'll need to have, put as many leaves in as necessary, and then I'll go through the process of gathering that open bite. Here's just a quick video of an employee showing how we gather that data. So once we identify that vertical dimension and that tooth relationship irrespective of the teeth using mainly the jaw, then we'll put that material on, or a bite material on each side. In this case, we use Exabite from GC America. Put some on the posterior teeth, leave some space in the anterior. Again, have them closed down, trying to occlude on their back teeth, which they won't be able to, because it's an open vertical dimension. On that leaf gauge, it seats the condyle, positions their jaw to where it should be based on the jaw joint anatomy, and the teeth are not touching at the vertical dimension that we would want. Thus, we can obtain this record. Like I said, once that data is gathered, I will send the patient home and I'll get to do my homework. Yes, school is over, but when you get to these complex cases, homework is so important. Here is my homework workstation. I've actually added a monitor to help make this process more efficient, but usually I'll sit down with all the data in front of me and be able to analyze it and work through my process to help identify what are the best solutions. So I'll just show you that process. In the end, I end up with this document. We call it our informed consent. And again, I'll go over it in more detail with you just to show you what I do. So I'll go through and list all the diagnoses and findings, starting with the medical history, the dental history, their TMJ exam, and their aesthetic evaluation. I just want to show you in the aesthetic evaluation how important this is. So here's how we do it. You'll take this picture with their lips relaxed and apart. Some people call it in repose. And we measure that lip length. There's an average lip length for most men and women. Helps us better identify if the teeth are in the right position. Then we'll see if any teeth are visible. And in this case, you only kind of see that little tooth right there, which will play a role in how we determine what we should do in this person's case. Then we have them smile and see how far their lip moves. If it moves within a normal average and range, it gives me a better idea of what is going on with the teeth. In his scenario, right, we couldn't see any of his teeth when his lips were relaxed. Normally, a man of his age with the lip length he has, you would see a little bit of his teeth, his maxillary teeth, and we didn't see any. So that starts to tell me something's going on with those teeth. And then we can see in his smile they're worn, and his lip movement's pretty normal. So we know likely there's some room to rebuild his upper teeth. In the lower jaw, a little more complicated, right? We could see one of his lower teeth. And that means those lower teeth are in a more ideal situation, even though they're worn. Then you'll notice little things like the dark space back there, missing tooth, some of his gingiva is visible. Those are all important things to identify as we talk about it with him. And there again, you can see the wear of his teeth. We talked about seeing that canine, or I identified seeing that canine in his repose position, and that means that is really where the teeth should be, that height, even though they're worn. Then you'll see the erosion and different things to talk about as you go through the case. Now, with this data, I love doing an analysis of getting teeth the right size and shape. So here I usually outline what the teeth form looks like now, and then overlay that with what a normal quote-unquote tooth size and dimension should be, so the patient can see it. And you'll see we're probably missing easily 2 to 3 millimeters of tooth length if we're trying to obtain the ideal height to width ratios, which most teeth present with. And then you'll see in the lower jaw, if that canine is the right height of where the teeth need to be, we can only really increase that length of the anterior or the worn dentition a little bit. So it helps me have to figure out like how are we going to do that. Fun process. I love doing this. So then it helps us come to the occlusal evaluation. And one of the main things we noticed is he appears to have a loss of occlusal vertical dimension. What does that mean? Means his jaw closes further than it should if his teeth were normal position and height. So it gives me some warm fuzzies that there's going to be ability to increase the size of his teeth appropriately. Because if we make the teeth taller, that vertical dimension increases. And if the vertical dimension is normal, you get a little bit more worried that increasing that tooth size and length will be hard for the patient to do. So in his case, it's pretty favorable that I felt like we had a little bit more space to increase his tooth size back to normal and not be too worrisome that he may not tolerate that increase in vertical dimension. And then we have this last section of other things that we noticed that might be of value to his treatment planning process. I'll then look at all the teeth individually, with the photographs and x-rays or radiographs, just to identify if there's anything else going on that might be of concern for us. Then I'll look at the CT scan, especially since we go back to this slide, you'll notice on tooth 31, something looks like isn't in the best condition there, right? Likely a vertical root fracture with that tooth. So that tooth will need to be replaced. So the CT scan can help us analyze that data and identify if that's possible or what it would take to make it possible. So again, we'll look at those images to help us clarify and identify what's going on. Then, again, here's my current setup of how we do that. You'll notice on that second from the left screen, there's a table or chart that I'm going to go through here. I show that because when I'm going through that table, I'll have up all the x-rays, all the images, tooth charting, and even trying to have the CBCT up, because I'll make a detailed list of every diagnosis on every tooth. This is super important for my team, especially when they strive to bill insurance and maximize somebody's benefit. Insurance companies want a detailed description of all diagnoses, and so this helps make it easier for my team to bill their insurance appropriately. It also helps me show the patient exactly what's going on in their mouth. That's a lot of data to go over, and a patient gets super overwhelmed. Legally, I feel like we have to do that, and just for the benefit of the patient to know what's going on, they need to know that. But it can be overwhelming, so I try, after going through that with the patient, which I'll show you that we do that in a minute, but I try to then summarize the data into some key indications for treatment, simplifying it so they know, hey, here are the things that are going to be in the way of me as a dentist providing them what they want. That's the main point of the first visit, is understanding what they're hoping to get to and what they want. And so all that information I just gathered will be overwhelming. And so simplifying that is helping them see, okay, here's what you want. Here's the things that are going to be really harder or need to be addressed to get you to what you want. So in his case, the occlusion is a huge factor. At this point, it's pathologic. There's no mutual protection. There's no canine guidance. There's severe wear and erosion. There is a reduced vertical dimension. And then factors that will affect our success is, where's that erosion coming from? Where's that attrition coming from? And there's that fractured tooth. So once we gather all that data, I'll still continue to proceed with my homework and start to decide what are the best solutions possible for this person. And so in this case, I put together a table of the upper jaw and lower jaw, so the maxilla and mandible, and start listing what solutions or treatments are going to be needed to help him. So in the maxilla, we ultimately decided that rebuilding his teeth is the best solution for him, which would be utilizing ceramic crowns on all of his remaining teeth. And same thing in the mandible, is to put ceramic crowns and replacing the broken tooth number 30 with a dental implant. And so in the end, he should have the result of ceramic crowns replacing the damaged and lost tooth structure with new prosthetic material at the proper occlusal vertical dimension with the proper articulation of the teeth. And that's the ultimate goal. That will provide him with the most successful and comfortable and functional result if we can achieve that successfully. So a huge important part in this process of treatment is seeing if he can tolerate that and identifying the ins and outs and details of how he can tolerate that. And so we always put in there a prototype set of crowns or prosthetic teeth. We'll explain how that works in the next steps, but that prototype set of teeth allows me to provide him some function stability, evaluate how he's going to do with this new tooth relationship, aesthetically, functionally, and phonetically, before we move on to a definitive ceramic, beautiful tooth. We get to work out the details in his prototype teeth. Honestly, I never do these types of cases without doing that anymore. There's just so much data and so much perfection that can be obtained through the prototype set of teeth. So here is the treatment sequence that I would propose. Ultimately I have to meet with him and discuss the treatment in detail, discuss with the anesthesiologist. Well, that's one thing I forgot to mention. He's super anxious about dental work. Even being in the chair for his consultation and exam, it was really hard for him. And so we feel that him being sedated and asleep during these more extensive procedures, he will benefit from tremendously. So in that process, he will have to sit down with a dental anesthesiologist who is a specialist in anesthesia in the field of dentistry, to be prepared for his visits. Once they go over that, then we'll schedule him for what we call the prototype phase. On that visit, he will be asleep. I will prepare and adjust every tooth appropriately for the receiving of those prototype crowns. We'll obtain the records to do that as well. And in our lab, the same day, we'll design and mill beautiful prototype acrylic crowns. Once we're all done, those will go in and he will return home with those prototype crowns. We will usually see him in a week to see and evaluate how he's doing with them, again, functionally, aesthetically, and phonetically. We may make adjustments. We'll see him as many times as needed until we feel that he's going to tolerate and receive the appropriate crowns and restorations in his mouth. If we need to, we will remake them. If aesthetically they're just not where they need to be, if functionally they're not where they need to be, then we'll take the data that we gathered during that prototype phase and remake them until he is comfortable and stable with our design. Then you'll see we jump down to the fabrication of the ceramic crowns. The ceramic crowns require final records at the new determined vertical dimension and relationship of the jaws and the aesthetics that we understand from those prototype teeth. We will then send all that data to our lab and they will fabricate some beautiful ceramic crowns. I feel very lucky to work with our lab. They are honestly the best lab I've ever worked with. They are absolutely phenomenal. They make teeth look real and natural, and they fit perfectly if I give them the records they need. And then we would deliver his final crowns. You'll notice in this process, there's a phase of the implant insertion and completion. We'll discuss this with the patient. If he wants to finish his teeth and then get the implant and crown after the teeth are in, then we'll do that. If he wants to wait to get his final teeth after he gets his implant in to get the implant and crowns all at the same time, then we'll do that. But that's the basic sequence. I put that together because my team is super efficient, but they need to have that detailed sequence to make sure everything always flows and is prepared for appropriately. I think that's why our office does so well with these complicated cases. We have a definitive outline that everybody knows and everybody's on the same page, so the patient can understand that and feel that, and they just gain so much trust and respect for the process that they're getting taken care of properly. So once we put all that together, then my team will schedule our patient back. We call that visit 2, which is our treatment discussion. At this point in time, they'll be introduced to our treatment coordinator, which is Danelle. She's absolutely phenomenal. I can't ask for anyone better to work with us on these patients and these situations. It's super complicated and super detailed, and I'm very particular about how it's done so that we can provide our patients with the best experience possible. And so she has a really important role in helping people along with that, and she does absolutely amazing at it. So we'll then sit back down together away from the clinic in a consultation room, and go over all those details. Usually we'll record that treatment discussion if the patient allows us to, so they can go back and review it. They have more information, they have better understanding, and usually proceed with treatment more efficiently. Then Danelle will take our plan, put it into a summary, and put it into her what we call white Bible, so that she always knows what to do and follow up with the patient appropriately. So in this case, our patient said, yeah, let's do this. And so she made the sheet, put them into our system, and she started scheduling all the necessary visits. They coordinated with the anesthesiologist. Ultimately, it leads us to our third visit, which is the preparation and insertion of our prototype restorations. I'm just going to quickly outline that process that we go through. We always start with a verbal consent with our patients, just reviewing everything we're going to do. Patient meets with the anesthesiologist, then they meet with me to review that consent. Then our assistants gather some additional data that day, and then patient goes to sleep. I do the clinical work, and we get all the records needed to send it to the lab to make those prototype crowns the same day. Once that's done, the lab starts designing those prototypes and fabricating them. Our patient starts to wake up and rests in our office, being observed the whole time, and then we're able to deliver those crowns when they're completed and the patient goes home. So let me just walk you through some pictures of that process. So here's some of the records my team will gather. Here is the occlusal dimension that we hope to work with. We confirmed the color that they wanted. This time he said B1. Then I will go through and reshape all the teeth appropriately to receive these new prototype crowns, maintaining that vertical dimension. We send all that data to the lab. The lab then starts the design process. These are just some of the pictures showing how cool that process is. You notice the pictures allow them to provide a virtual try-in of our design. Once we do the design, they'll have me come over just to prove it, see if there's anything that I see from a clinical perspective that needs to be adjusted. Here's just pictures more close up about that. Pretty cool. Seeing the changes that are made, the restorations that are designed. Ultimately, then they are fabricated into milled PMMA prototypes. Here's what they look like in the patient's mouth. A significant change for this person. We have to talk about that they're going to notice. Just a total different change of where their bite comes together, how it feels, their tongue space, phonetics, aesthetics, and they learn to adapt pretty quickly if we're close. And so we put them in, adjust them the best we can, and then they go home. But this is how they look for him. Obviously, you can see a couple things if you look really closely that we will want to change. If they're not very large or significant, then we talk about them and move forward. So we get them in and check on all those things. In his case, we didn't have to remake them. We adjusted his bite a couple times to where he felt really comfortable and he wasn't destroying or breaking or knocking off his temporaries. And so he was able to move forward pretty quickly. And thus, you'll see that tooth was out. Let's go back here. On that lower right side, the tooth was out, so we made a little bridge while that area healed. And because we could move forward quicker and he wanted to complete his ceramic teeth without that implant crown being done, we proceeded to what we call visit 4. 4 plus is just all the follow-up visit. Visit 5 would be our final records. Let me just go over the outline of that. Again, we always do a consent with the patient explaining, hey, this is what we're doing today. Do you have any questions, concerns? Here's what to expect. Here's the risks. And if they say, yeah, let's go forward, then we do. Our assistants then gather quite a bit of information and then I'll do some clinical work. Ultimately, it's refining the preps, making them perfect and smooth, and getting the records we need to really have the lab make the best fitting crowns we possibly can. That is something super important. I don't always feel that we get that unless we spend some detailed time doing it. It has to be perfect. Otherwise, the lab cannot make us something that fits the teeth properly. And so I really, really focus on that. So there's the basic steps to do that and getting the lab the records they need. Then we put their existing prototypes back in and they go home. Then I'll write a very detailed lab prescription and get everything to them and spend some time talking to them in person to make sure that we get the outcome that we want. So here's the records, just going through that. Here's his prototypes. Here's a pre-visit scan of his teeth with the Trios. Here's a pre-data gathering with a bite. Here is those teeth in that relationship with his bite. These particular images are after we packed cord and refined all the tooth surfaces to make them very smooth. And here is a bite record to help maintain that. In my process, I still do a polyvinyl siloxane impression. My lab loves it. They don't always fully trust the digital for final crowns, so I'll make sure I give them the most detailed impression I can. I always look to see if something doesn't come out right in the impression. You'll see here this did not. The impression material folded here. So then I'll make another one to capture that in great detail. We do the upper the same way. You'll see, oh, there's a bubble. That is not appropriate. We need to make sure it's better. So we then make another one and fix those things. Once I'm sure all my records are replicating what is in his mouth perfectly and what we need the lab to do, I'll write a very, very detailed lab script. Again, talking to them, sending them everything they possibly could have, so then they can get all the records put together in the lab to create the final restorations. So here's those impressions mounted. Here's them using the dies that they trim beautifully so I see the margins. So when they make the crowns, they fit the margins perfectly. When you have a crown made, you do not want any open margins. That's a space between the crown and the tooth. And there are techniques that can avoid that and minimize it to the best possible. It just takes diligence and a level of perfection or desired perfection that you're willing to go through. The lab then takes that data, just like we did with the temporaries, similarly anyways, and goes through and designs a new set of teeth. And ultimately, they then take that design and make ceramic crowns out of it. These particular crowns are zirconia. And so you'll see here, before they fired them, they designed them and milled them. And then they're putting them into the oven here. And in the oven, they fire them and sinter them into this ceramic. And here's some beautiful pictures of how our lab technician will texture and prepare those crowns to make them look as real as possible. He just does an absolutely phenomenal job. This shows too the translucency of these materials to make them look lifelike, and then he'll finish them to put a surface texture on them that's very similar to natural teeth. I just can't explain enough how hard this is to do and how amazing our technicians are. Our main technician, his name is Dale Bischoff, super phenomenal. Honestly, to get this kind of work done, this would double the cost of the work that we do if we were to use an outside lab. But because Dale works with us, we're able, he's our lab technician. He's part of our team. He's just like one of the doctors here. Absolutely phenomenal and does the best work I've ever seen. I can't express enough how hard it is for a technician to make zirconia teeth in particular look this good, look like real teeth. And you'll see in a minute when we deliver them how amazing they look. Again, if you were to go anywhere else to get this quality of teeth, your price tag would be 2 to 3 to 4 times as much because of the cost. So here they are. They're ready to go in. We call this visit 6. It's the insertion of the crowns, quick outline of it. Again, we go over consent with the patient, explain what's going on. They verbally say, yes, let's go. Then we do the clinical work. This is just the basic steps of doing that. Each step is ensuring that everything fits perfectly. We don't just go throw them all in or at one time. I go through and make sure each one fits each tooth perfectly. If I confirm that, then I put them all in together, verifying that the fit between the teeth and the bite is good. Then the patient approves, evaluates them to see if they like them. If they don't, we don't deliver them. And then if they do, then I insert them usually 2 or 3 at a time to make sure they just fit. Every time you cement some in, there's a little discrepancy in how they fit together. You just have to confirm and adjust the interproximals that they fit perfectly. It's kind of a tedious process, but it is phenomenal and is absolutely necessary. And so once we're done, the patient goes home. Let me just show you the outcome of this case. I think they look beautiful. They turned out really, really good. So they look natural, the character in them, they fit around the gums really, really nicely. He loved them. You can see some of the detail that Dale put in them just makes them look real, even to the slight discrepancies in color of different teeth, because natural teeth have a little bit of discrepancy in the color. Now, if you don't want that, that's fine. If you want your teeth to be all perfectly white and more symmetric and even, because that's in our culture today, a lot of people want that, we can do that, but we just have to fine tune it to what you would want. This particular case, he really wanted them to look real, and Dale did a phenomenal job. Here's a closer up view. Here's even a closer view. I love this image because it kind of showcases the character and how it looks in his mouth and how healthy the gum tissue looks. In his case, we still needed to do the implant in site 30, so the implant's been in at this point, and we helped direct that by designing where it should go, making a guide, having it inserted, and then once it's healed, we go in and make an impression. So we did that digitally. Here's that impression, and then once it was made, we inserted the crown. I threw in the radiographs at this point to show you how well everything fits, and that implant crown in site 30 and the bone levels with it are superb. Couldn't ask for something to turn out better. And I mean, the way the crowns fit, there's no open margins. They're smooth, they're intimate with the teeth. The way they fit together side by side is ideal. He's not going to get any food hopefully stuck in between the teeth because the contacts are not open. And his occlusion was really good. We fine-tuned that even after the final restorations to where he felt comfortable. And we always fit them with a night guard. So if they're grinding their teeth at night, they're doing it with some protection over their teeth. And here you can see how they turned out again. Everything's done. Just a phenomenal job. Super grateful for our whole team. This does not happen just because of me. Happens because our team is absolutely dedicated and amazing. They want every patient to have the best experience possible. We want every patient to find the value of the investment they've made in their mouth. We stand behind our work, and our lab is just phenomenal. And so just to showcase again Dale's phenomenal crowns in the end, I can't take credit for how amazing they look. I can take credit for the importance of the diagnosis, the treatment planning, the coordinating, the preparation of and the records provided to the lab, the discussions with the lab of ensuring it is exactly what we need clinically, and then Dale just finished it off with some phenomenal work. So there you go. That's our patient here before, and then after. You can see up close again, before and after, and everything kind of side by side. Pretty awesome. I feel very fortunate to be able to work with wonderful people and wonderful dentists that trust us to refer their patients in. In the end, if you're looking for this kind of work, just come get a hold of us. We'll do everything we can to help you receive this type of result for you. Obviously, every situation is different and requires its own approach and dedication, but we are super excited to be there to help anyone at any time receive the best quality and care of work possible.